Today's topic from obgy and gynae, antepartum hemorrhage. ठीक है, हम एंटीपार्टम हेमरेज पढ़ेंगे आज, द पैरेलल क्लिनिकल पाथवेज उसके फ्रॉम पैथोफिजियोलॉजी टू लाइफ सेविंग मैनेजमेंट. सो लेट्स स्टार्ट. फर्स्ट इज एंटीपार्टम हेमरेज, दैट इज APH. इसकी डेफिनेशन कॉस्ट पढ़ेंगे. डेफिनेशन, ब्लीडिंग फ्रॉम और इनटू द जेनिटल ट्रैक्ट occurring from the period of viability, that is of 28 weeks up to the birth of the baby, that is defined as antepartum hemorrhage. ठीक है, on the day of conception to the 28th week, which is period of viability. From that period of viability to the delivery, that is the danger zone of antepartum hemorrhage. What are the causes of antepartum hemorrhage? That is abruptio placenta, that is the most common. Accidental hemorrhage भी कहते हैं. Second is placenta previa, that is second most common, and other like vasa previa, local causes like polyps and cancer, or circumvallate placenta. Okay, there are two mechanisms of failure. First is placenta previa, second abruptio placenta. In placenta previa, there is a mechanical shearing. Okay, here in the diagram you can see there is a cervix, a lower uterine segment. There is a placenta placed in the lower uterine segment, and there is a fresh bleed. What is the location of placenta previa? Lower uterine segment, and mechanism is uterine contractions or dilation. Force is shearing force, gives the shearing force, and that opening of intervillous space. ठीक है, the result is placenta does not separate. Blood is maternal. The blood which is flowing out is the maternal blood, and there is no thromboplastin release. Okay, and abruptio placenta, it's a systemic rupture. In the upper uterine segment, there is placenta, there is a hematoma, decidua basalis. ठीक है, blood in the lower uterine segment, decidua basalis. The location of abruptio placenta is upper segment, normally implanted. Mechanism is rupture of vessels in decidua basalis, causing hematoma. That hematoma separates the placenta. As you can see in the diagram, the hematoma is causing a separation in the placenta, and the thromboplastin is released in abruptio placenta. In placenta previa, there was no release of thromboplastin. In abruptio placenta, thromboplastin is released. In placenta previa, okay, what's the placenta previa? It's the obstruction, the anatomical mistake of implantation. Okay, and now we see etiology. Why here? The dropping down. There is a large placenta. Large placenta is dropping down in twins, in triplets, or in succinturate lobe, and there is the other is defective upper decidua. Okay, there is a history of C-section or a curettage or a drain and curettage or a myomectomy, multiparity, advanced maternal age that is more than of 35 years, or smoking. These can be the etiology for placenta previa. We will have classification in type 1, type 2, type 3 and type 4. In type 1 it is lateral, that is edge in lower segment more than 2 cm from OS. Okay, from type 2 it's marginal. Marginal is edge reaches the margin of the OS, that's the opening, okay, orifice. In the posterior there is a dangerous variety, it's in posterior, that's why it is in a dangerous variety. We have two os, external os and internal os. So we have here that os is we are talking about. Type 3 is incomplete, that is partially cover the os, and type 4 is complete cover of the os. Okay, modern clinical standard, any edge within 2 cm of internal os is significant. Then placental migration in 20 weeks or 34 weeks. In 20 weeks, the mechanism differentiate growth of the lower uterine segment. In the third trimester, shifts the placenta relation to the os. Key takeaway we will take in that diagnosis confirmed in the third trimester. Best time for USG, what's the best time for USG is 32 weeks to 36 weeks. Okay, now the clinical signature of previa. There is a triad of symptoms. It's painless, it's causeless, and it's recurrent. Because it's recurrent, we say it the warning hemorrhage. The bleeding is bright red, which means it's fresh bleed. The uterus on palpation feels soft, relaxed and non-tender. The fetal status is reassuring, head often high or floating. The diagnosis, we come with the do not touch rule. Warning is the golden rule in APH more than 28 of weeks. The per vaginal examination is contraindicated because it's a risk of torrential hemorrhage. An investigation choice is transvaginal ultrasound. The measure exact distance to the os, and it's safe, accurate, measures exact distance to the os. You can see in the diagram we are doing a transvaginal ultrasound. Okay, Now second is our abruptio placenta. It's the detachment. Okay, it's accidental hemorrhage or uterine apoplexy. The definition for abruptio placenta is premature separation of a normally implanted placenta before delivery. There was a normally implanted placenta, but before delivery it got prematurely separated. The risk factors are systemic and traumatic. Vascular systemic shows a hypertension, chronic or pregnancy induced hypertension, it's the major cause. Then advanced age, multiparity, or thrombophlebitis, that is folic acid deficiency. Then we have lifestyle is vasoconstriction, smoking, cocaine abuse, or the mechanical trauma. We have sudden decompression, polyhydramnios or first twin delivery, external trauma, that is falls or road traffic accident or short cord. These all are the risk factors for abruptio placenta. Then we have classification by bleeding pattern. If it is revealed bleeding, concealed bleeding, or it's a mixed bleeding. In the revealed bleeding, we can see the visible bleeding through the cervix or vagina. We are seeing the visible bleeding, but in hidden concealed, it's a hidden danger because it's a deep proportionate shock, and we can't see the bleed from the vagina. And in mixed, we are seeing the blood from vagina, but there is also a hidden danger, a concealed type. So it's a mix of concealed and visible bleeding. The clinical signature of abruption. Okay, there's a fetal distress going on here. The symptoms comes with abdominal pain, continuous or tearing, and tenderness present. The bleeding is dark red and non-recurrent. The uterine tone is woody, hard, tense, and rigid. The fetal status is distress, common is distress, and absent fetal heart sound. The systemic storm, there is a complication where the placenta releases thromboplastin that results in consumptive coagulopathy, that is DIC, disseminated intravascular coagulation, which is coagulary uterus. We will call this uterus as a coagulary uterus, that is blood extravasation into myometrium, and the myometrium looks blue in color, so the uterus we call the blue uterus, and it's not an indication for hysterectomy. Okay, it can cause renal failure due to hypovolemic shock. Then the grading of the severity, grade 1, 2 and 3. Grade 1 is mild, where we have minimal separation, slight bleeding and normal fetal heart sound. In grade 2 it's moderate, there is a moderate bleeding, uterus tender and fetal distress present. And grade 3 it's severe, it's heavy bleeding, revealed or concealed. The uterus is woody hard uterus, there is a fetal death, and because it's fetal death it causes also DIC. Okay, behavior in the diagram, that is a uterine tension is occurring there and there is a concealed bleeding over there. The clinical showdown. We have features and difference between placenta previa and abruptio placenta. The onset of placenta previa is insidious, abruptio placenta is sudden or stormy. The bleeding color in placenta previa is bright red, it means it's fresh bleed, and abruptio placenta is dark red. The pain is, placenta previa is mainly painless, but in abruptio placenta it's severe pain. The uterine tone in placenta previa is soft or relaxed. In abruptio placenta, the uterine tone is woody, hard and tender. The fetal parts in placenta previa it's easily palpable, whereas in abruptio placenta it's hard to feel because the uterine tone is woody hard. Okay, the precipitation factors are none in placenta previa, but there is a hypertension trauma that can precipitate abruptio placenta. Then we have high yield associations. In placenta previa there is malpresentation, that is transfer lie or breech position. Then stall-worthy sign, that is fetal hearts FHR, fetal heart rate slowing on head compression. Then placenta accreta, that is a risk with prior C-section. In the abruptio placenta we have retroplacental clotting, the clot, and the postpartum hemorrhage or coagulary uterus, the blue uterus. Then we have general management. We will do the resuscitation first, stabilize the mother to save the baby. First, admit and monitor continuous maternal and fetal vitals. Then IV access, large bore cannulas with crystalloids and colloids. And the third is blood bank, cross match immediately to receive blood or transfuse blood as required. Then anti-D for Rh negative mothers. If the mother is Rh negative, so we have to give her the anti-D serum. Then assessment questions, that stable mother है कि नहीं है, live fetus है कि नहीं है, mature fetus कितना है, more than 37 week है या नहीं है. So we have to assess this first. Okay. Then we will manage the previa, the waiting game. We have two, that is expectant management, that is a McAfee regime, and the active management. In McAfee regime, the criteria we follow is mother stable होनी चाहिए, bleeding stopped होनी चाहिए, preterm less than 37 weeks होना चाहिए. Okay, then we are doing the Merriweather italic action, the bed rest, steroids, and no PV. In active management, the criteria will be the severe bleeding, fetal distress, or more than 37 weeks. We will the Meriwether Italic cesarean section standard for type 2, post 3 and 4. The managing abruption, the ticking clock, that is immediate assessment, then stabilization, then delivery mandatory. Never do expected management. Delivery is mandatory. Okay, here we have to deliver the baby. Vaginal delivery is preferred if patient is stable plus labor progressing. Key step is to amniotomy to reduce pressure and thromboplastin release. And in cesarean section, if severe distress, live baby or labor stalled, so we have to do an emergency C-section. We will have a summary of strategy. In placenta previa, there is an architectural problem. The pregnancy is preserved, avoid disruption, and plan the C-section. In the systemic problem, the rupture placenta, we have to resuscitate aggressively, deliver immediately, and fight the DIC, disseminated coagulopathy. Okay, the partial displacement or detachment here, that's placental position, the internal os. Then in the end, I will say the two lives we have to keep it in balance: the maternal survival and the fetal survival. The maternal survival we will assess by airway and circulation. We have to stabilize hemodynamics. We have to ensure adequate oxygenation. We have to manage hemorrhage and coagulopathy. For fetal survival, we have to optimize placental perfusion, continuous fetal heart rate monitoring, and timely delivery. Early recognition, accurate differentiation, and decisive management are the difference between tragedy and survival. And this, your quick thinking, your turns, and everything you do, your process, it will decide the maternal survival and the fetal survival. Okay,